So welcome back everyone, hope you had a refreshing break. We've got 2 talks now to follow and then some time for Q&A. For those of you who might have joined after the introduction, just to remind you that the best way to ask a question is to use the Q&A rather than the chat box. So you'll find the Q&A with the little speech bubbles somewhere on your screen. And if you put your question in there, we can either answer it directly in the screen itself, or one of the speakers will answer it live. Meanwhile, in the chat, we're posting a few links to, for example, our next meetups for ARPKD parents. And we also have a few adults with ARPKD who join those, and also to certain pages on the website. So that's great. Good to see everyone. And Manish, I will pass over to you now, as you are so admirably chairing the sessions and can introduce our next speaker, Tassos.
Thanks, Tess. I think I'm just really introducing some fantastic speakers. I mean, welcome again, everybody. We've had 2 excellent talks, initially an overview and then what's new. And then it's a delight to introduce to you and invite my colleague, Tassos Grammatikopoulos, who is a consultant paediatric hepatologist at King's College Hospital, King's College London. Fantastic resource for this really unusual, rare condition, which unusual for doctors as well. And we often would pick up the phone and try and speak to Tassos to help us with children who have got an additional liver problem. And Tassos is going to give us an overview of that and then take some questions. Thank you, Tassos.
Thank you very much. Thank you for inviting me again to speak to this great day. And I hope everybody will find interesting the talk. I am fully aware that it's a mixed audience, so I'll try to keep addressing all across the panel. So some of it may be boring for some of you. I'll try. Jane, thank you very much for the support. I'll try and share the screen now, if I can, and then that's perfect. Thank you. Right, so as I said already the thank yous. I don't want to delay further the presentation. So if we move to the next slide, please. Okay, so I'll start with a little bit of the basic anatomy from the liver disease point of view and how the liver is structured and how we can understand a little bit of how these ciliopathies and more specifically, the autosomal recessive polycystic kidney disease liver involvement starts. So the canal of herring it's called like that because it's meant to look like the herringbone. It starts, from a central vein on the right-hand side, and then the major blood flow on the venule blood comes back and forth into the portal field. That's all lined up with hepatocytes that eventually starts differentiating towards cholangiocytes, and that happens in a small area inside the liver that's called the portal tract. And in that small area where the portal tract is, we'll have eventually a portal venule, a hepatic artery, a small vessel, and also we'll have a bile duct at least. Now, when there's a problem with the bile ducts, eventually the liver in itself is trying to change and convert some of the hepatocytes into more cholangiocytes to form more ducts and more advanced ductal system in order to try and drain bile, for example, if there's any obstruction downstream into the liver. Next slide, please. Now, cilias, as such, we all know, just to remind ourselves, first described in, I think, in the 1600s in Protozoa, and then gradually, by Grisham in 1963. And we know that they do 3 main functions. They do the mechanosensory one, where we look into, changes in the flow inside the bile ductule and the canalicular space. We look into the chemosensory one. If we can have the next slide, please. chemosensory function, whether any changes in the bile composition, i.e. if there's more bile ducts, if there's the acid, hydrophilic or hydrophobic component of the bile changes, what's happening with the electrolytes, what's the calcium influx or not. These are being picked up by cilia, and that's a way of reacting to this. And then there's also the osmotic pressures, you know, how high is the pressure inside the system, and that again is regulated through a calcium channels and influx. Next slide, please. The embryological process, we know, just to remind you very quickly, you know, we start from an budding of the apical membrane in the cholangiocytes, and we're talking here about immotile cilia. That's what we're interested as liver doctors. We start with a basal body. There's a protrusion through the apical membrane. Then we start having the formation of the intraflagellal transport system. Past the transition zone, the axoneme start being formed, and then eventually that's being populated with ciliary vesicles and other molecules that eventually will form all the way to the distal appendage of the cilia itself. And then more recently, we've started to know about other structures outside perhaps the cilia itself, like the exosomes and the role they play in the liver disease. Next slide, please. Now, ciliopathies in the, we know there's about 100 conditions so far. There's some more known than others, and there's a whole variety of conditions affecting the kidneys mainly, but also the liver that we don't have a clear label about it. And there may be up to 72, and that's the last review, but that's quite a long time ago now, and I'm sure there's a lot more that we know about. Next slide, please. So the mechanism, I'm sure, Larissa, I'm sorry I missed your talk because I was on call, but I still am. But there is a very complicated mechanism there. There's a lot of theories behind it. In the liver itself, it may have to do with changes in the microRNA, small molecules that have to do with our genetic coding. It may be an inflammatory process with an influx of cytokines. It may have to do with hormonal changes, growth factors, then calcium, again, very important. And it may also have to do purely with just changes in the pressure inside that biliary structure, the ductal draining system of the liver itself. And that all, I think, some of these aspects have been investigated more than others in terms of trying to explain the pathophysiology of the liver disease in itself. Next slide, please. Now, when we look into the liver involvement, you can see that we're talking about immotile cilia, and that the kidney and the liver on the bottom right-hand side of the slide, they come very hand in hand. And there are conditions like ARPKD that will present perhaps simultaneously, or maybe the liver will manifest itself later on, or more recently, as we have realized ourselves, that we may even pick up patients with a process happening already in the liver, where they developed already the liver complications that have a degree of renal involvement, or they have been identified with a ciliopathy related gene, not so much ARPKD, but other conditions. And that's very interesting for us as hepatologists. Next slide, please. And I'm always fascinated with the interaction between this, genotype-phenotype association. And I enjoyed Max's talk very much about the registry and, the first association to pinpoint, for example, what are the genetic mutations associated with the development of portal hypertension, or the overall complications from liver disease as such. And I've read that paper with a lot of interest. For me, on this slide, the main box in the middle of it is really the The gene associations involved in a pathogenesis in specific structure of the cilia that can affect the liver and the kidney. And we found in a lot of our patients that they may come across or used to come across from various centers for a liver assessment that had been classified as ARPKD, but they didn't have a genetic diagnosis. And then when we initiated the genetic diagnosis, the result we got was not what we expected. So that generated more interesting discussions with our nephrology colleagues, Manish being one of them. And we saw, you know, changes, not just the liver, but we also saw changes in the pancreas as well. And I'm sure, you know, the field is open out there. And that's really something that we as a medical society and researchers, we have to look into a lot deeper. Next slide, please. Now, this is a variety of all ciliopathies, but when we look from the liver point of view, before we have a diagnosis in the kidneys, we have congenital hepatic fibrosis as a condition that we will put that diagnosis histologically. We have radiological appearances that we call like Arolis disease and syndrome and the polycystic liver disease conditions without any renal disease. And then we have conditions like more rare, like neonatal sclerosing cholangitis, where again, some of these patients will present with renal cysts, and that complicates a little bit the condition. Yes, albeit they will not have the typical ARPKD appearances, but the liver disease is already there manifested. Next slide, please. Now, ARPKD, you know the incidence, we talked about this, it's about 1 in 20,000, but when you look into liver disease overall, then that becomes even rarer, with, you know, autosomal dominant polycystic liver disease being extremely rare as an entity, but that's not the purpose of this talk. Next slide, please. Now, from the liver point of view, in patients with ARPKD, they can present to us or be referred to us because of abdominal distension, pain that has to do with purely the size of the liver, or it may be associated with the size of the kidney as well. And the pain may be because of the tension in the capsule of the liver, or it may be from a possible infection if they get cholangitis. And that effect also can have complications such as sepsis and decompensating liver disease. Patients can have low local back pressure, hypertension, something, you know, my previous co-panelists alluded to. Patients can have gastroesophageal reflux, they can have problems with feeding, but most importantly, and that's the information I've got, but as I said, Max probably will have more updated information, you know, from American registries on ARPKD. They can have portal hypertension, and I'll explain a little bit about this. In about 20 to 25% of these patients, they can get infection, that's up to 5%, and more dramatic events such as cyst rupture and sepsis, which can really put a patient really at a very compromising situation. Next slide, please. When we investigate somebody with ARPKD or a ciliopathy related condition, you know, we always, from the liver point of view, we check the liver function test, the urea and electrolytes, we look at the GFR, whether that's been tested already or not. And then imaging really does help, because you will differentiate, and I'll show you some slides, will differentiate for us whether we talk about liver fibrosis or whether we talk about a multicystic condition. And we'll do an ultrasound scan as a first line, look at the vascular anatomical structures there, and also do an MRI or MRCP as a second line investigation where there is evidence of ductal changes or cystic changes. Liver biopsy is something we would do in patients if the diagnosis is not clear, and we have some immunohistochemical tools. We'll be able to stain the tissue and look for evidence of cilia-related pathology. We always look for other organ involvement, and genetics is really, for me and my colleagues here, you know, with something we will do for every patient that presents to us for the reasons that I've explained already. Next slide, please. So these are patients of ours that we had in the past. You know, you can clearly see the difference between a patient with ARPKD, you know, with the cystic changes in the kidneys. And on the right-hand side, there's a patient with Joubert syndrome, which is a different kind of ciliopathy related. And you can see the difference in the liver itself, where there's a small shrunken liver with a massive spleen on the right-hand side of the picture. I'm sorry, I can't move the mouse around.
Do you want me to move?
Yeah, you can do. Yeah, that's the spleen. Excellent. No, that's the liver. Yes, very fibrotic. And then you have a massive spleen going all the way down to pretty much the inguinal fossa. Thank you very much. Next slide. So this is a patient, another patient we had who's post her first renal transplant as such. She's from another renal unit, and she was diagnosed, she was labeled as ARPKD. You can see on the left-hand side imaging, you can see this biliary kind of circuloid, like a bunch of grape structures inside the liver, which is the cystic changes that we see. And then eventually on the right-hand side, you can see the transplanted kidney there at the bottom. That patient was diagnosed as ARPKD, but had mutations in TMEM67 as such. And these are, for me, very interesting and waiting to see. And that was part of my question about, you know, how many variants in other genes we find in ARPKD phenotyping patients. Next slide, please. This is liver histology. We always enjoy a bit of liver histology in all our talks. So you can see, Jane, on the bottom left, we can see these structures that are bile ducts. They should look nice and round, but they look more elongated. They look a little bit more stretched. And this is kind of the ductal plate malformation that we call in patients with ciliopathy related conditions. On the top right hand side, I don't know if you can see the very small dots along the big cystic structure. You can count one or two. No, inside the yes, there. This is the alpha tubulin staining, which is staining for a part of the structural component of the cilia. It should be nicely lined up with dots, all that, but in a patient with PKHD1 variants, that's very patchy. And when you do further, you know, confocal microscopy, then you will see that the cilia may be a lot shorter, the orientation may be different. Overall, they look grossly abnormal. Next slide, please. And this is, I'm sorry if it gets a little bit too gory, so we'll see a few explant pictures now. So this is a patient again with diagnosed with nephronophthisis and liver disease. So we can see that this liver is not a healthy one from the, first of all, from the color of it, and it looks quite fibrotic, and there is some nodularity around it. It normally should be nice and smooth. Next slide. And on the back side, you can see perhaps on the right-hand side of the margin of the organ, you can see a little bit more nodularity there. With the basal structures, you know, in the middle of it, you can see the gallbladder. Next slide. And this is what it looks on the inside, where there's an extensive fibrotic process there inside the liver with very small cystic changes as such. But on the next slide, when you have a patient with a polycystic liver disease as such, this is an explant. Again, you can see the dramatic changes where there's a lot, you know, pretty much the liver has been all taken up by cystic changes. Next slide. I'm not going to dwell very much on that. That's the external appearance of a liver from a patient with Autosomal Recessive Polycystic Kidney Disease. Again, you can see how much different it looks and how much cystic in its nature. Next slide, please. Next slide. I think you had enough of that. Okay, so one of the major complications of how we manage the liver disease is, because we'll talk a little bit about pharmacological treatment, is portal hypertension. The main complication, remember, 1 in 4 patients may develop portal hypertension. So that's an increased pressure in the blood flow in the system, connecting all our intra-abdominal organs, the gut, that's filtered through the liver and then past the liver into our heart. Next slide. So you can see on that image how the anatomy, exactly as I described it, the big blue vessel going inside the liver, that's the portal vein, that's where the pressure goes up, that's when we start having complications in terms of if the blood cannot progress through the liver, then it has to divert through other routes, and the most easier route of these is to go through the left gastric veins, and then eventually form these big juicy vessels at the end of our food pipe that put patients into risk of GI bleeding. And if we see the next slide, please. These are endoscopy pictures from patients, with scopes at King's, where the big red on the left-hand side, the big red structures, this is, you see your food pipe from the top, and that's your GI junction, these are the varices that will go and treat, and these are the ones that if they rupture, they can put you into risk of bleeding. On the right-hand side, you're looking at the rooftop of your stomach, and you can see a big, I don't know if you can see, if Jane can point out this big structure next to the black thing, which is the scope on the right-hand side with a small red dots on it.
Are we looking?
Yes, yeah, that's it, perfect. So this bit is a varix that has bled, has got stigmata on it, and this is the cause perhaps of a potential bleed. And that will be something that we'll treat in all patients. Next slide. Again, more imaging of that. You can see the varix on the right-hand side and then telangiectasia on the right. Next, please. Other complications that patients can get from ARPKD is ascites. That's mainly from the liver decompensation, and if the liver stops doing its synthetic function, i.e. producing albumin, and the GI bleeding that I talked about. So I'm not going to dwell anymore on this. Next slide, please. Now, when we do these investigations, and when we started treating a lot more actively patients with portal hypertension, because in the past, up until 10 years ago, we would only scope patients if they had a bleed, but now we are actively, and that's changed in the pediatric hepatology world, we actively do surveillance endoscopies and screen our patients who have evidence of hypersplenism. And by that, I mean that the platelets have dropped below 100, and if they have an enlarged spleen on ultrasound scan. But because we're trying also at the same time to minimize the number of procedures we do in our patients, then we'll go and look from a research point of view into some other parameters, some other biomarkers, some other investigation that can give us that answer without putting a scope down. And the next slide, for example, a very helpful tool that we found is transient elastography, where we measure mainly the spleen stiffness, because the liver stiffness, especially in patients with portal hypertension, will be high, but in multicystic liver disease, that's very difficult to measure. It's inaccurate. So we will measure the spleen stiffness, and from that we'll be able to extract some helpful conclusions about whether we need to do liver and upper GI endoscopy or not. Next slide. GI management, it's fine. I'm not going to talk very much about it. The management is the same for any patient with ARPKD, any kind of liver disease, and it consists of fluids, antibiotics, and then more invasive techniques in terms of treating the varices. Next slide. These are some of the banding devices we will use in case you come across, God forbid, you come and meet me in theaters, and I'll start talking to you all technical about what we're going to do. These are some of the things we will be using. Next slide. Next slide, please. Okay, now how we treat from the liver point of view. Surgical treatment, then the very extreme conditions, procedures such as fenestration of cysts, resection of cysts, if they become very problematic, i.e. everything else is relatively preserved for the child with ARPKD, but then a specific cyst causes either significant pain or a cause for recurrent infection. But that's mainly has been tried in other parts of the world and mainly in adults, and the outcome is really not very good. Pharmacological, we'll talk a little bit about, and then the question of the transplant, which I see is coming already on the chat there. Transplant or not, and what type of transplant, and when do we do the transplant? So next slide, please. Now, when we looked into, if you understand a little bit about the impact of a polycystic liver disease in patients, that's a study back in 2018 where they looked into the quality of life of patients, albeit, you know, they were adult patients, depending on the volume of the liver, and they classified that into mild, moderate, or severe, mainly on the number of cysts they had and the actual volume they measured. And they find, not surprisingly, that the larger liver volume had a higher symptom burden, and they looked into symptom scores that had increased as the disease progressed. So they measured a physical component score where it had to do with how much activity they could do, how much they could go about their daily life, and then how much energy they felt they had. So not surprising, the physical activity was decreasing as the disease was advancing, but that wasn't in parallel with the mental component score. So it was mainly a physical aspect of the disease. And then moderate and severe patients had lower physical component scores than the general population. That's no surprise to anybody. Next slide, please. This is a from 2016-17 database from NHSBT. I've got something more up to date. And you can see that we do quite a significant number of transplant across the UK. That's UK data. But when you look into pediatrics, where perhaps we would have done multi-organ transplants, there were only like 4. And out of those, only a proportion of these, i.e. 2, were used, you know, for a liver kidney, and that was not for autosomal recessive polycystic kidney disease. That was for other conditions. So all in all, it's very rare for somebody to need liver transplant or even a combined liver kidney transplant. Next slide. And you can see the reflection and the percentages here on this slide were highlighted. You know, this is a slide when there was some regulatory changes done in the organ donation for kidneys back in 2019. But you can see, I just want you to take home the percentage of children that actually have liver or liver and kidney transplant. And if we see, for example, the pediatric elective liver and liver kidney, about 110 will be adult, will be liver only, then that leaves us a very small number of patients that perhaps had liver kidney transplant. And again, that's usually for metabolic conditions. So overall, very rare. Next. Just press once more, Jane, please. Sorry. Yes, that was more up-to-date data. I can tell you that there's only one patient, though. This is the data that actually, I don't know if it's, we all as a transplant society looked very much into what kind of activity we had just before the pandemic and just after the pandemic. And you can see that in 2020, just before lockdown started, there was one pediatric liver kidney transplant in the UK. Combined. Next slide, please. Now the transplant outcome, that's earlier data. So I'll be interested, as I said, to see the most up-to-date. So 200 patients, only 16% of them had combined liver kidney transplant. 5-year survival was very good. And you see that though the combined kidney liver transplant was slightly worse, the survival, than it is for isolated kidney transplant. And then there was the age and sex adjusted risk for death that was 6 times greater than those with just isolated kidney transplant. Next slide, please.
Tassos,
Yeah.
could we maybe wrap up in a couple of minutes?
Yes.
Just
Yeah.
because
Yeah.
you're generating a lot of very good questions.
Oh God. Okay. All right. So outcome, I just want to highlight here that the liver kidney, the take-home message from me on this slide is that the liver kidney transplant waiting times and the age and everything else is really driven by the kidney as such. You will see the difference, how much lower are the waiting times and the weight and everything else for kidney, for isolated liver transplants than it is for liver kidney transplant patients. Next slide. Next slide. Treatment options are these are all very classic ones. You know, we'll put patients on ursodeoxycholic acid, especially if they have biliary component in the biopsy, if they have cystic changes, if their ducts, if their piping system looks abnormal. And there's some novel approaches that are still in experimental studies. The most important thing we had done from the liver point of view has been done, had to do with sirolimus, an mTOR inhibitor, and see what effect it had in the cystogenesis in the liver. And then we try to ameliorate, you know, some signaling pathways, the Wnt signaling pathway, very important in the ciliopathies. And also, you know, I was very pleased to see this new registry on tolvaptan, and I'll be looking into the details of that. Next slide. So in summary, that's my last slide, I promise. You know, there's a complex genotype phenotype for me in this. I would like to have all my patients that come through with a genetic result. Albeit, you know, it may be conclusive, but at least it will give me some better understanding of what I'm doing here and how much I can predict the future for my patients. It can be other organ involvement, not just the liver and the kidney, as we know. The mechanism of the disease is not fully understood, and the decision about whether a patient needs a transplant, whether that transplant will be just a liver or just a kidney or just a combined liver kidney transplant, is a very individualized one, and it requires a lot of discussions among specialists to come up with the right decision for this particular child. Thank you very much. I think the next slide is just a thank you. Yeah, okay. And I'm happy to take questions. Thank you. Sorry for the if I dragged.
No, Tassos, that was a fantastic overview, and you were not over time. I just wanted to allow discussion. So thank you for that. I think there's a question on the chat which you have already talked about, which was looking at somebody asked the question about what percentage of patients would receive a liver transplant. I'm presuming that is not necessarily limited to during childhood, but perhaps you might break that down for us, Tassos, from your few slides you showed, how many during childhood and how many afterwards.
Minimal, if not. I mean, as you saw, you know, there's maybe one patient that may have had a combined liver kidney transplant as such, and liver transplant in itself, it's, you know, counted in the fingers of one hand a year. So you can see if we do about 120 liver transplants in the UK per year in pediatrics, that's like 1%.
Okay. So that's really, I mean, that probably leads to maybe a related question. I think people might consider, you know, you highlighted 1 in 4 have
portal
issues
hypertension.
with portal hypertension, and quite often from a clinical service, you know, there are different children's departments looking after the children who have this condition. What would be in your eyes, you know, an ideal liver follow-up for children who have ARPKD? How often should they be seen? How should the team sit around? And, you know, what can the parents sort of wish for, perhaps, or ask from the nephrologist?
I mean, patients, if they have evidence of hypersplenism, as I said, where the platelets are below 100, that's our cutoff, and have splenomegaly, then they will be offered in all 3 liver centers in the UK. And as I said, that's kind of the international consensus now. they will be offered an endoscopy. Depending on the findings of this endoscopy, then the follow-up and the management they receive, the follow-up will be planned accordingly. So it may be, that they need more frequent endoscopies, or there may be just every 1 or 2 years where they have a surveillance endoscopy to treat preemptively any viruses that they may have, that a potential GI bleed can put them in a compromising situation, not just from the liver point of view, but also from the kidneys, from the hemodynamic changes. Somebody who does not have evidence of hypersplenism, then they should have come at least once a year, or have an ultrasound at least, and a set of blood tests, albeit it may be in the renal clinic, and then we'll have a discussion to say, well, listen, this child I've been following up for 5 years, all of a sudden I see changes now in the ducts, I see changes in the blood test, and we'll be more than happy to see these patients.
Thank you. I might just request Max to perhaps initially comment on any learning experiences from the wider registry about follow-up. There are good models out there which you've been able to point out to perhaps what we do at the moment.
It very much fits to what Tassos has described. I think we in the general registry we have I think 5 patients with isolated liver transplant amongst 690, so it is a rare condition. We have some combined liver kidney transplants, I think 25 or 30, somewhere in that range. My feeling is that the longer the disease progresses and the older the patients are, the more the liver is put into the focus. So the older the patients are, the more the liver sort of becoming more and more important. I absolutely want to support the point that although the disease is called polycystic kidney disease, it is not just a kidney disease, and sometimes we as nephrologists tend to see these patients first, and as a society we may still need to learn a bit more about teaming up with hepatology early during the course, and I think that would be a very, very important point. Maybe just one more thing. I also agree with the genetic point that you made, Tassos. So from our registry, we have genetic data for about 45% of the patients, roughly. So not all of them are genotyped. It's the clinical diagnosis first. But obviously we do then have some patients who later on were diagnosed with what we call a phenocopy, so with other genetics as the basis. Over the years, by now, this has been about 30 patients. So they are out there, and TMM67 is a common finding that you mentioned. PKD1 is the most common that we see, but TMM is a common differential diagnosis, and I think we're learning a lot in this field, and we've now started to sort of always compare the findings of the whole registry with the ones of genotype patients to not run into any false findings.
Fantastic. So just really sifting through the questions, I think there's a question from Barbara just talking about her, she's talking to us about her 5-month-old baby who has ARPKD, has had bilateral, so both kidneys have been taken out for, and she mentions that the liver is enlarged and there are some cysts. So I think the specific question which we could perhaps have a stab at, Tassos, is I would like to know if the liver can repair and get smaller. Her liver function is good. So just general points. We obviously can't go into specific details of the questions, and then she has posed a follow-up subsequently, which I'll request Jane perhaps to sort of direct that later. But is there any data around, once the cysts are there in the liver, sort of with some of the treatments, I think you mentioned sirolimus, are there anything there which reduces the growth of the cyst for Barbara? Thank you.
Unfortunately not. I mean, the cyst in itself, as we know the data in pediatrics, because that's the other question about what's happening in the young adults, and there are complications around it, is so the cysts in themselves, they don't cause a problem as long as the liver is doing the synthetic function, as long as there's no portal hypertension, and that's something that comes from a close follow-up over the years. It will not be anyway if something, if the liver is struggling to cope, it will not be a sudden onset. It will be something that gradually we clinicians and, you know, we'll see them in clinics, we will pick up on that. And I know, you know, Larissa put on the chat as well, you know, about the combined liver kidney clinics that, you know, they do in Birmingham and we do here with you guys, you know, and the GOS as well, where we discuss the patients. So I wouldn't worry about so much about the cyst, but I would really worry if at some point, you know, the patient, this child stops having liver follow-up in one way or another. The complications for me also is what happens with them as young adults, as I said, because once you get to a certain size and age, then the implications of going into a liver transplant list are different, and the way you've been assessed is different, and the way things may progress for a young adult are slightly different. We're learning through that, and I'm sure we'll learn through the registry as well about the outcome in the young adult population.
Yeah. Tassos, one quick question from Sarah. I'm wondering whether liver transplant is ever used because of portal hypertension when there is reasonable liver function in ARPKD. So normal liver function, but just portal hypertension.
It will be in ARPKD.
Yes.
I don't think so, but portal hypertension is a major indication for liver transplantation in itself. So we will have patients who are not responding to endoscopic treatment, who are not responding to conservative pharmacological agents, and these patients will be brought to a transplant listing meeting to be listed. But as far as I'm aware, and the data I had seen is that there isn't anybody, but I stand corrected, you know.
Yeah. No, fantastic. I think there are a number of other questions which, you know, hopefully we can discuss at the time of the panel discussion. So we are running 5 minutes over to what I had sort of penciled in for this. So I'm going to sort of move on to the next talk.